gastroparesis with the clinical patient in mind. Mr. R, the 25-year-old store manager from Thane, Maharashtra, presented with complaints of vomiting for 3 years and loss of appetite and weight for the last 3 years. The vomiting was non-bilious, non-projectile, non-blood-stained with food as content in 3 to 4 episodes per day. He has no history of weight loss, about 58 kgs. He went from 110 kgs to 52 kgs. And there was a gradual loss of appetite over the last 3 years. He previously had symptoms of COVID, but was RT-PCR and negative in September 2020. After 1 month, he had started developing recurrent vomiting, which was on and off for 50 to 30 minutes after food intake, both with solids and liquids, and the symptoms persist till today. There were no other clinically significant history. I would like to ask the forum what they think their differentials are. How do you do this? I already did. We had a myriad of differentials to consider given this history, and however, all the localizing historical signs were absent. So I had the following. The differentials that we considered for this patient was there was no history of early satiety or dysplasia, abdominal pain or loose stools, abdominal distension with jaundice, dark colored urine, or pale stools. There was no history of retrosternal burning, epigastric burning, or regurgitation. And there was no history of fever, no history of angina, dyspnea, fatigue. There were no lower UTI symptoms, and there were no similar history of illness in the family. He had been evaluated extensively for this problem in over 10 hospitals under gastroenterology, general medicine, psychiatry, neurology, and ENT. He had done several investigations outside of CMC, which had shown gastric emptying. Studies showed gastroparesis moved to liquids and 40% radiotaper detection after 2 hours. Outside gastroscopy showed gastric erythema, and CT abdomen showed non-specific mesenteric lymphadenopathy. Reactive manner. On examination, he was a young gentleman, conscious and no obvious distress. His pulse rate was 72, BP 160. He had no pallor, ictus, cyanosis, clubbing, lymphadenopathy, pedal edema. He had no dental enamel erosion, parotid gland enlargement, lanovo-like hair, calluses on the dorsal surface of hands. He had flat nails. His systemic examination was also normal. The possible differentials we considered for this clinical presentation was initially gastrointestinal causes like an obstructive lesion like alveolar or a gastroparesis or inflammatory bowel disease, but there was no history to supplement that, and there was no history of abdominal distension, as I said, and there was no history of early satiety or dysphagia. Other neurological causes we considered was migraines, uh, raised ICT, and psychiatric disorders like anorexia or bulimia. There was no history of headaches, seizures, blurring of vision, weakness of limbs, or deviation of the mouth. There were no meningeal signs, and there was no history of substance abuse or high-risk behavior. There was also no history of vertigo, tinnitus, hearing loss, or difficulty in fixating the eyes. Other endocrine causes we considered was Cushing's or Addison's or hypothyroidism, and he had no history of proximal muscle weakness, purple rash in the abdomen, easy bruisability, and he had no history of hyperthyroidism. Autoimmune consoles also we considered, and there was no history of joint pain, rashes, alopecia, oral ulcers, photosensitivity, claudication pain, Raynaud's phenomenon, or Zika symptoms. Their baseline investigations were done and were all found to be within normal limits. His HbA1c was 5.1 grams per deciliter. On imaging, gastroscopy done in CMC was also was normal. We had also done other investigations to consider differentials like heavy metal poisoning. Heavy metal screening done was negative. His endocrine evaluation, his TSH, ACTH, and ura was also negative, and his ATM cortisol was also within normal limits. We also considered acute intermittent porphyria as a differential, for which urine porphyrinobilinogen was not detected in urine. Other investigations for autoimmune markers such as ANA and ANCA complement were all found to be within normal limits. And normal CPK levels were also found. EMG run was also normal. Bone marrow aspirate also showed trilineage hematopoiesis with no abnormal cells. A gallium dotatate PET CT scan was done, which did not show any avid lesion throughout the head, thorax, abdomen, or pelvis. With all the differentials that we had in mind crossed out, we finally came to the conclusion that this could be an idiopathic gastroparesis. The definition of an idiopathic gastroparesis is objectively delayed gastric emptying of solids in the absence of a mechanical obstruction. It most commonly presents as nausea, vomiting, early satiety, belching, bloating, or upper abdominal pain. To diagnose idiopathic gastroparesis, however, the following etiologies have to be ruled out, which is diabetes mellitus and post-surgical complications from partial gastric resection or medication induced. Surgical surgeries causing gastroparesis can include partial gastric resections or vagotomies. Post-bariatric surgeries can occur, Nissen fundoplications, and post-lung and heart transplantations. Drugs causing gastroparesis are as follows. That narcotics such as oxycodone can cause gastroparesis, alpha-2 adrenergic agonists, tricyclic antidepressants, calcium channel blockers, dopamine antagonists, octreotide, GLP-1 agonists, phenothiazine, cyclosporin, and immune checkpoint inhibitors can also cause gastroparesis. The pathogenesis of gastroparesis is the pathophysiology of gastroparesis is that normally in the interstitial cells of Cajal in the stomach produce slow wave activity at a rate of 3 cycles per minute, and they arise from the fundus and go into the extend into the pylorus. On postprandial stimulation, they electromechanically couple with the smooth muscles of the stomach, which cause an action potential, which then cause the motor activity of the stomach to get transcended from the fundus to the pylorus. So there's the abdominal postprandial proximal gastric accommodation and contraction can cause a problem in the transmission of electrological signals from the fundus to the pylorus. There's reduced frequency of antral contraction due to autonomic dysfunction or abnormal intrinsic nervous system, which is mostly found in diabetic patients where hyperglycemia and glycated end products interfere with the can cause autonomic dysfunction. Oxidative stress is also known to cause gastroparesis, where there's an increase in number of macrophages and upregulation of heme oxygenase 1 in CD206 positive macrophages. There can also be impairment of inhibitory nitrogen oxide containing nerves and damage to the interstitial cells of Cajal. Rarer causes of gastroparesis include GI causes with delayed gastric emptying, such as post-infectious gastroparesis, achalasia cardia, atrophic gastritis, and functional dyspepsia and celiac disease can also cause gastroparesis. Other causes include chronic gastric infection, chronic mesenteric ischemia, median arcuate ligament syndrome, and alcohol. Non-GI causes with delayed gastric emptying include infections such as COVID, varicella zoster virus, Epstein-Barr virus, cytomegalovirus, Norwalk virus, and rotavirus. Collagen vascular disorders such as scleroderma, SLE, and amyloidosis can also cause gastroparesis.
Dr. Amrita, could you just wind up a
Sure.
clue because it's already time.
Sure. There have been several case reports of long COVID manifesting as gastroparesis, and this is one such case report which shows COVID-19 as also has gastrointestinal complications. The diagnostic studies which can be used to detect such an abnormality is gastric emptying scintigraphy, where an radionuclide is given to a fasting individual, and the transmission in the bowel is checked at 60 minutes, 120 minutes, 180 minutes, and 240 minutes. And a gastric retention of more than 10% of the
Would you be able to just synopsize what you did for your patient? How did you prove that the patient had gastroparesis?
In our patient, we had done a barium swallow, which had turned out to be normal. However, the barium swallow and scintigraphy studies done outside of CMC had shown abnormalities in more than 10% recession of the test meal at the end of 4 hours. And therefore, we had concluded that gastroparesis could still be a possible differential. In our patient, the management we used was mostly medical intervention, and we advised consuming small frequent meals, diet and low insoluble fibers, low fat diet, and small particle size diet. Drugs which we used were prokinetic antiemetics and PPIs. Macrolides such as erythromycin can also be used, and neurokinin 1 receptor antagonists like aprepitant can also be used. Newer modalities in treatment are gastric electrical stimulation, peroral endoscopic myotomy, and endoluminal functional lumen imaging can help in detecting prognosis after surgeries.
Can we just wind up, please?
Yeah, I'm done. This is a study showing the efficacy of peroral endoscopic myotomy in refractory gastroparesis.
So the next case will be presented by Dr.